Hi, and welcome to Healthy Living. I'm Debbie Lyons here today with Kelly Presnell, Public Relations and Marketing for Hilton Head Hospital, who's going to share with us a little bit about our show today.
Yes, Dr. Jason Snyder. He's an interventional radiologist who is going to be here today. He's based at the Bluffton Medical Campus in the primary imaging center that we've created a year ago. But he does work out of Hilton Head Hospital as well, but he's going to share what he does in terms of imaging services.
I'll tell you, he's an amazing interview. I think you all will really enjoy it because he's very, what I call, user-friendly. He can demystify and really share with us a lot about the radiology field because it's really exponentially grown.
It is, right, and even 3D mammography. It, you know, it's unknown, but it's known. Everybody knows about it, but they don't really understand it.
Exactly.
So he'll talk about that and just, you know, some other things that he does and you know, the importance of, you know, screening mammograms and how he goes about his regular day and collaborating even with our breast center and how they work together as a team.
Well, let's talk to Dr. Snyder.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hilton Head Hospital.
No one likes to wait, especially in any ER waiting room. I mean, when I'm sick or my family has a medical issue, I don't feel like waiting around with a lot of other people. Not to mention they're sick too. Honey. And my family does not wait patiently. You can imagine how uncomfortable and how long it can seem. But then I found out it doesn't have to be that way. I can check in online and wait anywhere I want. What's not to love?
It's the smarter way to ER at Hilton Head Hospital.
Hi, and welcome to Healthy Living. We're here today with Dr. Jason Snyder, and we're talking about radiology, and we appreciate your time today. I know you've got patients, and it's always busy here for you.
Very busy.
I mean, let's talk a little bit, if we can. We've got 2 segments to chat, and I thought we'd talk the first segment a little bit about you, and you've been here now
almost 2 years.
2 years. I remember interviewing you when you first came.
It's gone by quick.
It really has. Talk to me about your practice in general and what you all do here.
Well, I'm focused mostly on breast imaging, and me and there's another physician that comes from Savannah, Dr. Holsey, and we do all the breast imaging here. And we're here at this campus Monday, Tuesday, Thursday, and Friday. And then we're seeing patients on the island on Wednesdays.
One of the things I think that's really impressive about you, Dr. Snyder, is that you're fellowship trained in breast.
Right.
Why is that so important?
Well, it was
I don't know the answer to that, right?
Well, it was a dedicated year of doing nothing but breast imaging, and I trained in Charleston, and so you get to see a lot, and a lot of the very difficult cases and complicated cases go through Charleston, and you get trained by people who are also fellowship trained, and that all they do all day long is breast cancer.
What makes breast cancer so difficult and complex to actually diagnose?
Well, oftentimes it may blend in imperceptibly with normal breast tissue. And so it's almost a where's Waldo finding that breast cancer. You know, fortunately we have a new technology out, tomosynthesis, that promises to help find those cancers in that dense breast tissue.
What does tomosynthesis mean?
Well, it's a fancy word for a new type of X-ray or imaging of the breast, where it takes slices, multiple slices through the breast. Kind of like if you flip through a book and the pages, it's multiple slices like that. Or think of it as cutting a loaf of bread in multiple slices, so you can see the breast at different levels.
And would that be a screening procedure, or what someone typically would be diagnosed and then use it?
Right. Right now, it can be used for both, and
Okay.
because it's a newer technology, it can be used for both screening and diagnostic. And right now, we are allowing the patients to decide what they want to do with it. And we encourage patients that have, the denser breast tissue to highly consider it, because it does help us see through that dense tissue a little bit better than the regular screening mammogram.
Is it a mammogram-esque machine, or is it like a CAT scan machine, or is it like an ultrasound or 3D? Or
It's very similar to the mammogram machine.
Okay.
The positioning is very similar. It doesn't take much more time than a regular mammogram, and I don't think that patients will really know much of the difference, other
Right.
than it looks newer and more space age.
Oh, there you go. So it
Right.
looks a little funkier. And that's not the same as a 3D.
It is the
It
same thing.
is the same. Okay,
It is the same thing.
the 3D.
Yes.
So that means it can turn around and you can view things. At
No, not exactly. It's really not 3D. It's more 2.2D.
like you said. Okay.
And so it's more of just acquiring multiple slices
Got it.
through the breast.
Who would you recommend? Someone who's high risk?
Well, right now, the guidance is not clear exactly.
Okay.
The big study is still 8 to 10 years away,
Mm-hmm.
but the preliminary, smaller studies are showing that it is finding these smaller invasive breast cancers
Mm-hmm.
at an earlier stage in women who have denser breasts.
So let me ask you this. A woman goes into her gynecologist and has her breast exam and ends up goes and gets her mammography, and they find something. They come to you. They come to the surgeon. They come to you. What is typical protocol then for making the diagnosis and then coming up with a treatment plan? Is there a group that does that? And then how is that determined?
Yeah, that's a great question. So typically with a problem in the breast, either felt by the patient or their physician, they'll come see us first in breast imaging, and we'll work that up usually with mammography and ultrasound.
Okay.
And then make a decision on what to do next. Oftentimes it may be a biopsy.
Okay. So mammography we know. Ultrasound. What would that would be the next step? And what does that do that's different than a mammography?
Well, it's an adjunct to mammography. Sometimes there are lesions in the breast that we can see with ultrasound that we can't see with mammography.
Got it. Okay.
And oftentimes it just complements what we see at mammography.
Okay. So next we go to the biopsy.
Oftentimes it's a biopsy, and that's often performed with ultrasound if we can see it with ultrasound. If we can only see it with mammography, then
Okay.
we would use the mammogram machine
Okay.
for guidance for the biopsy.
And so the biopsy then is tissue is the issue, taking a piece of tissue?
We get a little piece of tissue. It looks like a tiny little worm.
Okay.
And we send that off to the pathologist. They look at it underneath the microscope and give us a result.
It's really interesting. My son's a radiologist, and we talk about it all the time. I think many people don't realize your role in actually diagnosing,
Right.
really the specifics of it.
Right. I'm usually the first guy that you see, and or the breast surgeon. And here, I work with Dr. Ringer. Our offices are next to each other, and so
Back forth,
we're
back
in
forth, back and
constant
forth.
communication with about the patients that come here.
So we have our biopsy now.
Right.
Take me from that point.
And so we get the result. Oftentimes, if it's benign, then I will see you back for a 6-month follow-up.
Got it.
If it's something that needs to be removed or needs additional imaging, then we'll set you up with breast surgery. Or if it's additional imaging, we may need to get a breast MRI.
And why an MRI? MRIs are not used for screening.
For the general population, it's not. We have a high-risk clinic here that we use breast MR for screening purposes.
And why would an MR be a better, not a better choice, but a second line of defense after mammography? Does it just show more?
That's a great question. With breast cancer patients, it's been shown that about 3 to 6% of the patients may have an undetected breast cancer in the contralateral breast, in the other breast.
Got it.
And so we want to find that cancer before they go for a definitive procedure, aka surgery.
Okay, which makes a lot of sense. So you're just sort of, and again, when you're doing the MR, would you do it of the body or strictly of the breast?
It's
or?
of the breast, and it includes both breasts. It also includes a portion of the chest and the upper abdomen. And oftentimes with breast cancer, patients may have findings in those areas as well. So we look at that area as well.
Are there, are there specific areas of the breast that are more prone to cancers?
Generally not. I think theoretically, kind of in the upper outer part of the breast where most of the fibroglandular tissue is.
Okay, makes sense.
And that's one of the reasons that we use one of our projections in regular mammography is to make sure that's included. But if you do this long enough, you know, breast cancer shows up everywhere in the breast. So it's really not specific.
When you make that diagnosis, all right, is there a board or a team? I do know that you have a terrific breast center here. Is it interdisciplinary, and can you share with us a little bit about how that works?
Yeah, I'd love to. It's Dr. Ringer and I work close together, and then all our breast cancer patients or non-breast cancer patients that are complicated go before our breast cancer tumor board, where all the disciplines including radiation oncology, surgery, plastic surgery, pathology, all come together and discuss each patient and devise a treatment plan for that patient, so that when that patient goes to see those other physicians, they've already been discussed in a multidisciplinary team, and that physician knows that patient already.
What are the advantages of having a multidisciplinary team look at you as a patient?
I think it's one, all the physicians in the care of that patient are up to speed.
Got it.
When that patient goes to see that physician. And two, just to get the expertise from different disciplines on how to proceed next.
How interesting. We're going to take a quick break. We're going to come back and talk to Dr. Snyder a little bit more about breast cancers and some of the other cool things that you do.
Certainly.
So stay with us. We'll be right back here on Healthy Living.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Low Country, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
We are back here on Healthy Living talking today to Dr. Jason Snyder about all the really fascinating things that he does. I think radiology is a field, is in the field of medicine very enigmatic,
Certainly.
if you will. And I've always been surprised there's so much physics involved in what you do.
Certainly, it all started with the development of the X-ray beam and being able to see in somebody's inside someone, and then from there it's just blossomed using ultrasound beams, the same things that the police use to detect how fast you're going, and the guys on submarines use to define mines, and then the MRI. That technology has helped tremendously in what we do, and then we also have functional imaging.
What is that? That's more like what's going on inside. I mean, you can see it, right?
The process imaging, and we often use nuclear medicine for that. So it's just a dynamic and changing field.
Is it interesting to see exponentially how things are growing? I mean, is it changing that quickly?
Well, there's so much research, and with the new technologies, there's always new applications for these new technologies, or someone has thought of a different way to use the same technology. And when it finally makes it into clinical practice, it's had to go through studies and be proven that it's actually beneficial to the patients.
When you're doing imaging, I've always wondered this, what are the actual goals of imaging? Is it diagnosis? Is it formulating treatment options? Is it?
Yeah, oftentimes it is diagnosis. And again, we're specialists that deal with nothing but imaging and procedures, and oftentimes the physician sends us a patient, refers us a patient to find out what's going on with that patient, and we give them an answer, and then they take that information and correlate with the entire picture of the patient to find out what's happening with that patient.
During the break, I was asking you about how often you follow your breast cancer or your breast patients, and I was surprised by your answer.
Well, hopefully, as long as they want to keep coming to see me, and they're here on Hilton Head, then as long as they're alive.
And then do you do routine mammograms as well as the more complex ones?
Yes, certainly. And specifically for our breast cancer patients, we have a protocol where we follow them real close for 2 years.
Okay.
And generally, we'll see them every year after that if everything's okay, and with diagnostic mammography, so that when they come here, I look at their mammograms and evaluate any changes that may arise while they're here.
Why are baseline mammograms so important? And I guess what I'm saying is, I have one at 40, and that is a critical time for me, and then to keep doing it after that. You like to look at this first one, or how does all that work with you?
Yeah, that's a great question. It's been shown that breast cancer saves lives in women in the 40-ish range. 40 is not a magic number. All of a sudden, you just don't start developing breast cancer.
Okay.
But 40 is the cutoff. And
so the mammographies will then save lives.
Right, exactly. And that first mammogram is very important because it establishes what your breasts look like.
Okay.
Now, we all have 2 eyes, or most of us do, 2 ears, 2 arms, and are symmetrical, but everybody's unique, and so each breast is unique as well.
Okay.
And so we want to establish what you look like, and so we can look for changes when you come back and see me every year.
I keep hearing the term dense breast tissue. What does that mean, and why is that a difficult or a more difficult tissue to look at?
That's a hot topic in radiology and in politics now, because the denser the tissue is, it's harder for me to see through that breast.
What does the density even mean? Is it that I'm bigger breasted? Is it the actual tissue?
Right.
Yeah.
Well, it's a
technical
exactly.
term.
Very. We'll get to the bottom of this.
Yeah.
It's basically the fibroglandular elements. The breast is generally made up of fatty tissue and fibrous supporting structures, and everybody has a different degree of that for their overall breast composition. Those women that have more supporting structures in their breast, the breast is denser. The X-ray beam, it's harder to get through, and it's harder for me to see.
Okay. So it could be hiding.
It could be hiding something. And that's one of the reasons that tomosynthesis, in theory, could help us find those smaller cancers that could be hiding in the dense breast tissue, because it actually takes pictures all the way through the breast.
At what stage can you actually see a cancer? If I can't feel it, can you still potentially see it?
Certainly. Generally speaking, those cancers that are around the 1 centimeter size range, you can start to feel it.
M&M size.
Exactly. And then
I know
hopefully,
my centimeters.
yes, exactly. And so we're able to see. Hopefully, we can see those cancers that are smaller than that. That's what we're trying to do.
Okay.
So it's finding cancers early. Early detection helps save lives.
Can you look at a breast tumor now and know if it's aggressive, know if it's, you know, I guess local in situ, is that what it's called?
Right, it's a great question too. Oftentimes you can, but there's so much overlap between some of the more aggressive tumors and things that are benign. And I tell my patient that's why I need to do the biopsy.
Okay. Let me ask you a question about incidental findings. I've always wondered about that. You know, why not just have a screening MRI at age 40? Just whoop?
Right.
I mean,
well, that's a great question because we use it in the high-risk patients and we use it with breast cancer. What it's been shown is that it leads to too many unnecessary biopsies. And so what would happen is my patients would become human pincushions.
Because if you're really looking, you're going to find something.
Right. It detects many things that aren't cancer, but that can look like cancer. And so then you're chasing a lot of things that aren't really cancer.
Is breast cancer viewed as a chronic disease now?
Well, in some patients it is, but hopefully that you're treated and recovered from breast cancer. That's where we want to eventually get you.
And I know we're talking a lot about breast cancer specifically. Can I kind of shift and go back? We were talking about different, I guess, ways of diagnosing. We talked about what an ultrasound does. We talked a little bit about what a mammography is and about the new 3D mammography. What is a CAT scan and how is that different than an MR? And then we started talking a little bit about the process of functional MRI.
Right. So that's a great question too. Right now, computer tomography is not used much in breast imaging.
Okay.
You know, it uses an X-ray beam.
Right.
And there's significantly more radiation.
Okay, in a CT scan.
Exactly, than is used at mammography.
I didn't know that. Okay.
And so, as a screening tool, it's not being used because of that increase in radiation. But there is some research going on with that, and I did some research in breast CT up in Charleston, and it's going on at several centers in the country to see if it can be utilized, because it is a great imaging tool.
And what would the point to find things earlier? To
find things earlier, and also to discriminate those lesions that are benign versus malignant.
Can you pretty much tell when you're looking at a breast if it's a cyst versus a tumor versus a this, that, and the other? Yeah,
oftentimes we can. You know, we don't biopsy things that we know are clearly benign, that have zero risk of being malignant, and there are certain lesions in the breast that have when you look at it, it has a very high risk of being malignant. And we know that when we biopsy it, it's going to be a cancer. And there are a lot of in-between lesions.
Well, and you know, one of the things that you said at the very beginning of our interview that sort of stuck with me, and that is you were talking about breast cancers or complex breast cases.
Certainly.
And I guess when you talk about complex breast cases that are not cancer?
Right.
Really?
Well, sometimes you know, patients have multiple lesions in the same breast or different breast, and so it requires additional imaging, additional biopsy, and additional strategies to work that patient up.
Really interesting. Are things like implants, or are there things that make imaging more challenging?
Certainly, implants do obscure some of the breast tissue, but we have specific views for patients with implants that gets most of the breast tissue into the field of view.
Well,
so
and
that
I'm
I can see that.
Right. I'm specifically thinking of people who've had reconstruction.
Certainly. Now, patients, there's several types of reconstruction. Oftentimes, our breast cancer patients have mastectomies and breast reconstruction with not much native breast tissue left, but of course, we have a lot of patients that have native breast tissue and implants.
I really appreciate you joining us today. I know you've got a crazy schedule, and,
You're welcome.
And thank you so much.
For having
thank you
me.
all for joining us here on Healthy Living. Again, we spoke today with Dr. Jason Snyder. Bye-bye.